Welcome, everyone. My name is David Hirsch. I'm the CMO at L.A. MS. Thanks for joining our renowned hosts and longtime friends of L.A. MS, Matt Callison and Brian Lau, in a multidisciplinary panel on the assessment and treatment of myofascial pain. Additional panelists tonight include Dr. Antonio Stecco, Dr. Michael Corradino, Dr. Lorenzo Gonzalez, and Dr. Jenny Nieters. As you may have seen before, to the bottom right of the screen, you will see two tabs, Questions and Chat. To notify us of any difficulties, please use the Chat tab. At the end of the presentation, we will use the Chat tab to post a promo code specific to this event. If you have specific content-related questions for Matt or Brian, please use the Questions tab. If you see any question posed by another participant that interests you, you can upvote to avoid duplication. You'll also see a tab for polls where we would love to have your contributions live. Please note that each webinar is recorded, and immediately following the conclusion of the webinar, you'll receive a link to view, and you'll be able to view the video on demand and on our blog. Thanks and enjoy, and we'll speak to you soon.
All right, David, thank you so much. Really appreciate that. You guys, thank you so much for attending this. This is fantastic, 8 p.m. on the East Coast. We've been planning this for quite a few months. Just give you a quick overview is that Brian and I are going to be giving about a 15 to 20 minute short webinar that's going to lead right into the panel discussion. And this is something that we have both been waiting for quite a long time. We've got some interesting questions to be able to ask them. So this really should be a great time. We'll have the question and answer afterward, but just like what David was saying is if you do have a question in the meantime, just put it right into the chat and we'll do our best to be able to answer that. But there will be a designated time for that question and answer. Something that's really exciting about this is that, can we go to the next slide there, please? Is that we invited these speakers because they're going to be participating in the Pacific Sports and Orthopedic Acupuncture Symposium that we're going to be putting on coming up in March 30th to April 3rd of 2023. Is there a next slide coming up there by chance? I think Stephen was on that, but he might. Yeah, here we go. Right on. Thank you very much. This is a symposium that we decided to go ahead and put together, and it is coming together really quite well. It's going to be here in San Diego, California, again, March 30th through April 3rd. And the speakers, the panelists that we have are 4 of the 16 different speakers that we have. So this is going to be really great to get to know these people a little bit closer and get their take on myofascial pain assessment and treatment. So that we don't keep you up too late tonight, I think we should actually probably kind of get started with this. The next slide is going to be showing all of our speakers actually, and it's got a blockbuster list really. So we've got Dr. Antonio Stecco and Dr. Rebecca Pratt, 2 leaders in the field for fascial research. So it's going to be fantastic to be able to hear what they have to say. Lots of top names within the field. And this is going to be really quite educational and a heck of a lot of fun. Brian, is there anything that you want to say as far as the overview before we just jump right into the brief historical reference of myofascial pain syndrome?
I think just happy to be here, and I'll be chatting in a little bit, but I think Matt's going to start off with a little bit of a history aspect first.
Yeah, good. Thanks. All right. So the next slide, please. So my intention with this brief historical review is merely to discuss the fact that myofascial pain syndromes have been observed for thousands of years. And it's interesting to see how far we've come. And I think it's pretty important for us to give credit to those before us whose research has provided important building blocks for us to evolve in this work. Now, this is something that I put together over the course of a week with quite a bit of research going into PubMed and Google Scholar. And there's a lot of people to be able to give acknowledgement to, but we just don't have the time. It's just a time constraint. So I went ahead and built this in a couple of different slides with this. And so let's just go ahead and give credit to these people. And for those people that are not on this list, of course, these are also very important pioneers in the work. So let's get started. So we start with the Ling Shu in the 2nd century before Common Era. There's description in chapter 3 of the Ling Shu talking about different individual pathology for every channel sinew. So the myofascial channel sinews. So the Jingjin is what it was known back then, and we still use that term today, but with the work of a lot of different people, including Antonio Stecco, Dr. Antonio Stecco, looking at these channel sinews as also these myofascial channels or myofascial sequences of these different muscle tissues, myofascial tissues that apply movement. So it's really quite interesting to be able to see in the past and also in the present. Now, the authors describe, there's quite a few authors of the link shoe, they describe a shrinking of the tissue, a tension within the tissue, painful nodules, drying out of fluids, rigidity, painful movements in each channel sinew. So it was observed there's painful points and different descriptions and signs and symptoms way back in the 2nd century before Common Era. Now, in the late 1500s, Guillaume de Bayeux, hopefully I said that correctly, a French physician, provided the first modern description of rheumatism and arthritis. Now, he wrote in detail about muscle pain disorders containing thickenings or nodular tumors, creating local and regional muscle pain. 1843, Robert Freip, I believe I said that correctly, Freip, I practiced that earlier, a German anatomist, made early mention of a condition that would later be known as fibromyalgia, so a leader in the field at that time, describing as rheumatism with painful hard places that could be felt in many locations on the body. So in the next slide, we're now moving on. In 1904, Sir William Gowers, a British neurologist, identified and defined the localized muscular pain condition known today as myofascial pain. He called it fibrositis. And in 1927, Dr. Fred Albee, who's really got quite a bit of credentials, he was kind of a rock star at that time as far as in the orthopedic world, a U.S. surgeon who invented bone grafting and contributed to advances in orthopedic surgery, rehabilitative medicine, was one of the first to introduce myofasciitis, which is really quite fascinating. Though due to a lack of research, this concept did not gain widespread adoption within the medical community, which is kind of fascinating to me because he was actually a little bit before his time, because if you Googled myofasciitis now, you would see all kinds of different articles about it. It even has an ICD-10 insurance code. So he was a little bit before his time before that was actually accepted in the medical community. Then in the 1930s, and in my opinion, Dr. Jonas Kellgren is the person that really started to change where we are today, understanding how muscle pain and trigger points and soft tissue indurations can be developing from the spine. And what he did was really some outstanding work. His quote was, "Distribution of diffuse muscle pain appears to follow a spinal segment pattern." And how he figured that out was that he injected hypertonic saline into various anatomical structures, into the fascia, the tendon, the muscle, in healthy volunteers, and charted the zones of the referred pain in the neighboring and distant tissue. Now, it's common to find Kellgren's work is referenced in modern-day research articles on muscle trigger points. So again, I think this was kind of the pivot point in the 1930s with his work, looking at how muscle pain is usually going to be having a component of the spinal segment. The next slide, please. Then in the same decade, 1939, Dr. Arthur Steinler, an orthopedic surgeon and educator, published over 120 articles, and he introduced the terms for the first time, myofascial pain and also trigger point, into the medical literature. Then in 1942, not too much time after that, we've got Dr. Janet Travell. She used the term myofascial trigger point to describe the hyperirritable spots, which can be felt as nodules and tight bands in the muscle tissue. And I think we can all agree that her work and also Dr. David Simon's work are still the foundation for many practitioners today. So it's a monumental work from Dr. Janet Travell and Dr. Simons. Now, recently, we have seen a lot of different pathophysiology of what is happening with myofascial acupuncture points, trigger points, and such. And the different concepts of muscle trigger points having a central and a peripheral sensitization was researched by Fernandez de los Peños and also Jan Damerholt. Their findings showed that growing literature supporting the concept of trigger points starting as a peripheral process that can contribute to and maintain central sensitization, which is quite fascinating because looking at lock short muscles, lock long muscles, postural imbalances. Can you go back to that slide? Yeah, postural imbalances and such. And looking at the periphery itself, signaling then into the spinal segment that there is going to be that sensitization. And this reminds me a lot of 1940s Dr. Irvin Core, a very famous osteopathic physician, and his concept of facilitated segments, thinking about how the spinal segment is going to be affecting the periphery, and then pathology within the periphery will affect that spinal segment. So the theories seem to really to be overlapping, which is really quite typical, is that we look at different people's work and we evolve people's work and we continue to grow. So this is where we are now, is looking at different Ashi points and trigger points and motor points, these different points that we're using in order to be able to help our patients. And we're using acupuncture to be able to treat that. So that was just a very, very quick historical reference to the myofascial pain syndrome, but I think it's really important for us to be able to note some of these people, because like I said, it's like they have the building blocks for us to be able to evolve and grow. Brian, do you want to take it over into the Ashi points?
Yeah, sounds great. And I failed to mention when we were discussing the symposium that there are a few poll questions on those. So feel free to check those out and answer those. And then I will continue now into the next slide. So we're discussing tonight myofascial pain, and myofascial pain is pretty broad, but we can look more specifically at myofascial pain syndrome, which often is discussing both the sensitization that Matt was talking about, and especially when you start getting into central sensitization and maybe even segmental, spinal segmental sensitization, that's a big component of it also. But in the discussion of myofascial pain syndrome, they're often talking specifically about trigger points. But there's a lot of things that can cause pain, a lot of reactive points, a lot of pain-producing points, a lot of sensitive points. There's a long history, as Matt was just discussing with that. So what I want to do in these next few slides is just look at some general basic physiology to give us a starting point to go into our first question for the panelists, to talk about reactive points. They can be painful, pain-producing points in the sense of actively when you press on them producing pain, but also physiological therapeutic type points that can be used in treatment when working with myofascial pain. So here's just a quick list. We have Ashi points. We'll talk about those, of course, motor entry points and intermuscular motor points, trigger points, various other soft tissue indurations, including nerve entrapments, and then centers of coordination, which I'm sure Dr. Stecco will talk a lot about when we get to it, and I'll give a brief introduction to it. So let's go into the first portion, just looking at the history from Chinese medicine, and that is Ashi points. Of course, all of us, if we're acupuncturists, have learned about Ashi points. Generally looking at these as being, points that you press on and the patient goes, oh, that's it, Ashi. That's the point. That's where my pain is. So these are basically painful points to palpation that are recreating patient's symptoms that they're describing. And that history goes way back into Chinese medicine. So that discussion has been a part of Chinese medicine really since for centuries. So Ashi points is something we've all learned about, but now as we're getting into more of an understanding of physiology, we can start looking at those Ashi points and what's causing them and what the underlying mechanism is that can create those painful or reactive points. So if we move on to the next slide. So within the sports medicine acupuncture program, we use and discuss quite a bit motor entry points. So many people know the term motor points. Motor entry points maybe is a better term to be using for this. This is where the motor nerve first pierces and enters the muscle. So this image we have here is from a dissection we did in the program. And it's a little hard to get your orientation when you're looking at that close-up image. But what we're looking at is the ulnar nerve. And if you look towards the bottom, it's a little hard to see. You see a needle penetrating through the fascia into a muscle, and that's the flexor carpi ulnaris. So what the hemostats are highlighting is that collateral branch off the ulnar nerve that enters, that pierces the flexor carpi ulnaris, and that would be the motor entry point, the region at which the motor nerve enters or pierces the muscle. So there's a lot of different kind of variation in language on motor points, but we'll discuss it as motor entry points as being that entry site. So let's go into the next slide and go a little farther with the physiology. So this is showing the posterior thigh, and what we're seeing is the sciatic nerve branching off into the various hamstring muscles. So if you look at this slide in this image, you'll see MEP, motor entry point. So that's the point at which it first pierces, in this case, the biceps femoris long head. And then PLP and DLP is illustrating that the motor nerve, once it enters the muscle, then sends out distal and proximal branches that go and create the sites of the region of the motor end plates of the muscle. So it's basically discussing the neuromuscular junction. Neuromuscular junction would be talking more about the sort of functional aspect. Motor end plates, more of the structural aspect, same thing. So motor end plates are the region on the muscle that have receptors for acetylcholine. So the important thing about this slide, and the reason we put this into the presentation, is to highlight there's the MEP, motor entry point, and then these intramuscular motor points, which is where the motor end plates are. And if you look at the discussion of myofascial trigger points, it's often described as forming. They can form anywhere in the muscle, but they form in the region of motor endpoints, or at least at high concentration of motor endpoints. So that would likely be these intramuscular motor points. The motor entry points are very mapped out. They're anatomical structures with a relatively high degree of consistency from patient to patient. There's, of course, variation in anatomy with people, but they are fairly consistent, whereas maybe it just hasn't been mapped out yet, but I think it's likely the case that the intramuscular motor points are going to have a much higher degree of variation from person to person. So when you work with trigger points, it's often by palpation that you're finding those regions that are the epicenter of that pain-producing region. And those are likely going to be forming, in many people's opinion, mine included, at these intramuscular motor points, which are the high concentration of motor end plates. So motor entry points, intramuscular motor points. Then let's go into the next slide and introduce trigger points, which is definitely something that a lot of practitioners are aware of. So myofascial trigger points are a hyper-irritable spot in skeletal muscle that is associated with a hypersensitive palpable nodule and a taut band. The spot is painful on compression and can give rise to characteristic referred pain, referred tenderness, motor dysfunction, and autonomic phenomena. So this is the definition from Travell and Simon's book, Myofascial Pain and Dysfunction, Trigger Point Manual. So it's talking about that aspect that you can palpate and feel these palpable nodules, palpate and feel these taut bands in a muscle, follow that taut band to sort of a region of hypersensitivity and a palpable nodule in that taut band, and then pressing on that can recreate characteristic referral patterns that you're seeing here for the iliocostalis lumborum and the longissimus thoracis that's being highlighted in this image. So for those who aren't familiar with these referral patterns, what you see basically is the dark red being the area that's the kind of the most likely referral zone for that, with the spillover area being the speckled aspect. Spillover area can be just as painful as the dark red. So that's not showing intensity of pain, just more consistency. 100 people and they had a trigger point in this muscle, the darker red would be the more likely area of referral, with the spillover area being pretty common too. So again, these could be anywhere in the muscle. They're not an anatomical structure, so to speak. You palpate through the whole muscle. It can be anywhere in there, but more than likely these form at the high concentration of motor end plates, which would be the intramuscular motor points. Right, so next slide. So myofascial trigger points are going to be in the muscle, muscle fascia. So there's a lot of other potential causes of painful points. These can be fascial, tendon, ligaments, nerve sites of nerve entrapments, including cutaneous nerve entrapment. So what you see in this image is a branch of the peroneal nerve as it exits in the region of gallbladder 37. And as it penetrates through that deep fascia, that could be an area that, if there's a densification in that fascia, could kind of strangle, pressure that nerve and create a paresthesia or a irritation or a pain within that cutaneous branch that's traveling in the subcutaneous tissue to reach its destination of the skin. Cluneal nerves would be another example of that in the low back. As they pierce through the thoracolumbar fascia, they can drape over the iliac crest and create pain in that iliac crest region, and then down into the gluteal region. So there's a lot of potential sites that can be pain producers from these cutaneous nerve entrapment sites that can be entrapped through the deep fascia as they penetrate and become more superficial. So lots of different pain producers. We could go into a whole webinar just on ashi points and pain producing points, but we'll keep it brief so we can get to the panelists. So next slide. So with Dr. Stecco will get into this much more, I'm sure. This comes from their research looking at centers of coordination, which is something that I find very, very interesting and a little hard to sum up in a very quick couple sentences. But basically, this has to do with the region within the fascia where a muscle that's only crossing one joint and another muscle crossing two joints, so a biarticulate and a monoarticulate muscle, where they communicate in the fascia. It's that region where that tension communicates to help coordinate movement in either movements like flexion, anterior movements, posterior type extension movements, lateral movements, internal rotation, external rotation. So it's a region where the fascia can help communicate that lines of pull to help create efficient movement patterns. If the fascia becomes over-densified, then that can cause inefficient movement patterns, which can lead to pain. And hopefully we'll go a little bit more in depth with this physiology. So these centers of coordination happen to correlate with very common acupuncture points. And even though trigger points can form anywhere in the muscle, they tend to have somewhat predictable locations. So these will also kind of correlate with common trigger point locations. So I think that leads us really into the first question that we're going to ask is, how does the physiology of these points, these painful or reactive points that all of us work with, whether it's acupuncture, manual therapy, and this realm of work that we do, how does your understanding of this physiology affect how you work and affect your workflow, affect what you do in terms of clinical work? I think we can open that up now to the panelists and see what they have to say, because all of us work differently from a different perspective, and it'll be interesting to see how what's different, what's the same, and what information we have from this.
I'll go ahead and repeat that question. I'm going to introduce the panelists here first. I had to make it a little bit more of an abridged edition because each panelist has a lot of different things to be able to say in their biography. If you want more information on them, you can go to soaseducation.com and look under that. Let's start with Dr. Antonio Stecco. So assistant professor at Rusk Rehabilitation, New York University, physiatrist, president of Fascial Manipulation Association since 2010. Assistant to the president of the International Society of Physical Medicine and Rehabilitation from 2012 to 2014. President of International Myofascial Society since 2020. He's personally made over 100 cadaver dissections for research. That always really excites me quite a bit. I'm sure Brian as well. From 2007, he organized and personally held theoretical, practical courses about fascial manipulation method in all the 5 continents. Dr. Stecco is the author of more than 50 extensive papers on fascia, co-authors of 5 books, and co-author of different chapters of international books, including this one that just came out within this last couple of years. It's written by his father. I mean, the whole family, Luigi, and also Antonio and Carla are just rock stars in the fascial world. This is an amazing book. Acupuncture, Western Medicine, and Fascial Manipulation that you can be able to get on Amazon.com. So it's just about in the 2 o'clock hour right now in Italy. So Dr. Stecco, thank you so much for coming. I'm going to continue to introduce everybody, and then we're going to come back to you and ask that question. Mr. Michael Corradino, thank you so much for coming. I really appreciate it. He's been a licensed acupuncturist for over 27 years. He's graduated from Pacific College of Oriental Medicine, San Diego, with a master's degree In his passion to combine traditional Chinese medicine with evidence-based neurosciences, he received his doctorate in 2005. Dr. Corradino has created a unique system of acupuncture named neuropuncture, which teaches practitioners how to neuromodulate their patient's nervous system back into health with electric acupuncture. Dr. Corradino has an educational program which the practitioner can receive a doctorate in neuroscience acupuncture, which I love the acronym DNA. It's almost as good as ours. SOAS.
I love it. I love it.
Yeah, it's fantastic, Michael. That's great. We also have another panelist, Dr. Lorenzo Gonzalez. Lorenzo, thank you so much for coming. Really appreciate it. Dr. Gonzalez has a doctorate of physical therapy from Miami University. He is a certified athletic trainer as well from the United States Sports Academy in Daphne, Alabama. He's also a licensed acupuncturist, right, from the Acupuncture Massage School in Miami, Florida. Dr. Gonzalez is board-certified orthopedic clinical specialist and board-certified exercise physiologist. My mouth is dry just talking about all this. He has a private practice in Dallas, New York City, and Miami Beach, specializing in treating Olympic, professional, and recreational athletes. Dr. Gonzalez is faculty of the McMaster's University Biomedical Contemporary Medical Acupuncture Program, as well as voluntary assistant professor of physical therapy in University of Miami Miller School of Medicine. Thank you so much, Dr. Gonzalez, for joining us.
Thank you.
We also have Dr. Jenny Nieters, has a clinical practice in Alameda, California, specializing in the assessment and treatment of sports injuries, pain, and athletic performance. Dr. Nieters is a team acupuncturist for the San Francisco 49ers football team and also the St. Mary's College men's rugby team. She's been teaching continuing education as part of Whit Reeves' sports acupuncture program, and her enthusiasm and concise treatment style makes Jenny's presentation enjoyable and always clinically relevant. Jenny, thank you so much for joining us. You guys, this is going to be fantastic. Let's bounce it right back to Dr. Stecco. The first question: there are several names for painful and reactive points that can be assessed and treated with acupuncture and manual therapy. These range from L.AC points, acupuncture points, motor points, myofascial trigger points, and fascial centers of coordination. How does your understanding of the physiology of these points inform your approach? And everybody, we've got just about 5 minutes each to be able to do this. So take it away, Dr. Stecco.
Well, thanks for the invitation first of all. So I'm going to talk about the center of coordination, that what we have, try to describe in detail and discover over the years. So the center of coordination is what coordinates what we call the myofascial unit. So basically, in any direction in the space, we have different motor units that will work together. Motor units that are localized in monoarticular muscle, biarticular muscle. So let's think about it. It's extremely complicated, sophisticated to make collaborate motor units localized in muscles that are mono, biarticular, with different leverage, with even different innervation, that have to contract at the same time. So this is extremely sophisticated task that the brain, of course, can organize, but you need a peripheral coordination, because you never know exactly what is the leverage, what is the strength of each single motor unit. So this is really, really complex. This is why we have the muscle spindle. The muscle spindle allows the different motor unit to be activated. But again, the muscle spindle, they need like a feedback from the local environment. So the muscle spindle is well known in literature. The capsule of the muscle spindle is inside the perimysium, so the connective tissue inside the muscle. And the muscle spindle are normally more localized like in the periphery of the muscle, so very close to the epimysium. And then we have described, in a robust way in literature, the epimysium, a lot of time, is in connection with the deep fascia through what we call the myofascial expansion. So we know, it is well known in literature, that around 30% of muscle fiber do not reach the tendon, but reach the deep fascia. So there's this continuity between a perimysium, epimysium, deep fascia. So why this sophisticated infrastructure? Because when you have the pre-activation with the gamma motor neuron, go inside the intrafusal fiber of different muscle spindle in motor unit that have to be activated simultaneously, well, the muscle spindle, the intrafusal fiber will contract, will stretch the perimysium, the epimysium, the deep fascia. So the deep fascia will converge the vector generated by the different intrafusal fiber of muscle spindle that works for all the motor units that collaborate for one direction in the space. So this is why into the deep fascia we'll have this pulling that will converge the minor tension generated by intrafusal fiber muscle spindle. This is why in the center of coordination is this specific location of the deep fascia where you have the conversion of the pulling of the intrafusal fiber of the different motor units to work in synergy. That is why in the center of coordination there has to be a perfect gliding between the different fascial layer, because a perfect gliding right there, it's mean that if each single muscle spindle will perceive the tension generated by the other synergic muscle spindle of each single motor unit. If you have a lack of gliding in that specific area, the different muscle spindle will not perceive the load, the tension generated by the other. So you can have an incoordination between different motor units that have to pull for the same purpose. For example, knee extension, the motor unit of rectus femoris, vastus intermedius, they have to feel each other to avoid patellofemoral chondropathy. So if there's a perfect gliding on the middle third lateral side of the rectus femoris in the fascia lata, the two parts of the motor unit in the rectus femoris and vastus intermedius will coordinate each other. So a perfect pulling, whenever you're doing a full extension of the knee, there will be always a coordination, how much you will contract the motor unit of the vastus medialis and rectus femoris. But if there is not a perfect gliding in the fascia lata on that specific area in the lateral side of the rectus femoris, midway between patella and anterior superior spine, well, the two motor units in rectus femoris and vastus intermedius will not coordinate. And so you have patellofemoral chondropathy. So this is the beginning of a lot of disorder, because as we say, in our opinion, we call densification, so a lack of gliding between the fascial layer is the beginning of many pathology, because at the beginning you have myofascial pain that with the normal imaging cannot be defined, but in NYU we now have a T1-RO, an MRI that allows to understand, to analyze this change of the viscosity of the extracellular matrix. We call densification. And when you have that, you start to have a problem in the joint. And why not? In the middle long term, myofascial pain can generate a real damage in the joint. So you can really have what clinicians see with a typical MRI or CT scan. So alteration of the cartilage, alteration of the tendon. So all the mechanical problems that we see daily in our office.
Excellent. Thank you so much for that. I'm really excited to be able to hear more about it. Thank you. That's excellent. Michael, would you like me to repeat the question, or do you think you're ready to go?
I think I'm going to take it. Yeah, I think I can go. So you're asking about the different points and the different kind of categories and the physiology of those points and how I go about treating those different kind of points, from sure points to trigger points to motor points and things like that. And what I would say is that each one of those has a different neurophysiological environment, right? Some of them are pathological and some of them are anatomically healthy locations. So my approach to treating pain in general using a neuropuncture system is we apply the Trinity, and we always look for the underlying root cause of that pain. Acute, acute versus chronicity is also something we have to look at, because we're going to be communicating and modulating the nervous system. And the pain can be at one area presenting, but it can also be manifesting in the central nervous system somewhere that also needs to be addressed. So with the neuropuncture system, we do like to use auricular to communicate with the brain and to do some nice autonomic stabilization and regulation. We also like to use the scalp system to communicate directly with either cortical structures or subcortical structures. And then if the location is more in the peripheral, we use, again, electrical acupuncture. And one of the things that I found to be most effective is I love electrical acupuncture. I use it on every patient. We do not use a lot of needles, so I like to keep the prescriptions very small and tight so that we address the underlying neural root pathology, not to confuse the nervous system. That's how we look at acupuncture and how we apply it. And we have specific dosages from microcurrent to millicurrent and different frequencies and time parameters and intervals. And something new that I'll be actually discussing at the conference, which I'm really excited to be presenting. I'll be presenting 2 really new ideas I've been working on for a couple of years now. So Matt and Brian, thank you so much for giving me this opportunity to present this content, but I'm really excited to do it. 2 of them, the main 2 categories of those areas are going to be to specifically isolate one particular nerve for really impactful neuromodulation for conditions like chronic regional pain syndrome, post-herpetic neuralgia, even in the face or the upper body and upper extremities, as well as even some internal medical conditions as well. And then the other area I'm going to be looking at, I know Dr. Stecco mentioned some of those gamma fibers and different peripheral fibers. What we're also looking at now is how to use electrical pulse widths to then recruit those specific fibers. And if we look at the classical Da-Chi model, the specific Da-Chi sensations can only be transmitted if they transmit along specific fibers. Those specific fibers have specific diameters. And with electrical pulses and with specific dosages, we can recruit that. And I think that's going to be powerful impact on the clinical application of this, specifically for specific conditions as patients present maybe with the same condition, but different sensory presentations. And we'll be able to isolate those nerve pathways and treat them. So I like to target nerves. I love neuroscience and neurophysiology, and we use electrical acupuncture.
Thank you so much, Dr. Corradino. I really appreciate that. We're off to a really good start.
Thank you.
Dr. Gonzalez, would you like me to repeat the question, or you think you're good to go?
No, I think I'm good to go. Thank you, Matt. Thank you, Matt and Brian, for having me. I'm honored to be here, especially following Dr. Stecco and Michael and Jenny right after. So my background is a PT, right? Exercise physiologist and acupuncturist. And so I work with a lot of athletes. And what we're describing here, you know, the clinical presentation when an athlete shows up into my office is, you know, they're sort of more about 2 things. This area hurts and I can't do something. And I think Michael touched on it. You have to look at the acuteness to the chronicity of it. If I'm dealing with a pro athlete who's been doing the same activity since they were age 5, and they're coming in to see me now, they're 25, 26, 30 years old. You're talking about 25 years of adaptations, centrally, peripherally, cardiovascularly, vascular, you know, so there's a lot of things that I've learned to incorporate into my practice to look at and to identify these tissues that cause pain. And so I do everything from thermography to using things like Moxie. I do VO2. I do musculoskeletal ultrasound to look at fascial planes. Are they moving? I do functional screens. And the screens I look at is really to determine patterns. Those patterns sort of lead me to exactly what we're talking about here. I can see tissues that become overly adaptive. And so where this athlete, when he was 17 or she was 17, 18, performing, let's say a soccer kick, I'm going to use just make up numbers, 20 muscles to initiate 100 pounds of force. Now it's taking them 25, 26 muscles to initiate that same force. So now you get compensations in tissues that are not supposed to generate force, and you're pulling from postural muscles. And so you have to look at all the different capabilities and tissues that manifest in the pain syndrome themselves. What are their true roles? What is their innervation? What is their referral pattern? And as you start doing this, you're able to sort of start quantifying, like Michael was referring to, what is the true source of the issue? And then with that, you change not only the fascial structures like Dr. Stecco referred to, but also joint, right, vascular. And I think that's what acupuncture opened up for me, was to understand the connectivity of the body on many layers through meridians and fascial systems. And so all these components that we're referring to tonight are different descriptions of pain syndromes that manifest themselves through overuse patterns, whether you're working at a desk and you're chronically posturally flexed forward, or you're a professional athlete doing something repetitively. And I found myself to try to go back and peel back the layers. And if you have to treat, you treat centrally, you treat segmentally, you treat peripherally, you treat the joint, you treat the muscle. And then I try to look at objective measures that help me quantify the changes that have occurred. EMG, again, ultrasound, MOXIE, VO2, all those things help me determine if I've made an improvement in their performance. And that's sort of what I want to sort of present, is to understand how this tension or load manifests itself in the body and expresses itself through the fascial system. And then you get pain syndromes, you get dysfunction in movement patterns, you get altered coordination of like hip extension, where you get hamstring before glute, things of that nature. And understanding, and to understand what can you do in the office that day to make changes.
Mm-hmm. Fantastic. Thank you so much, Lorenzo. Last but not least, Jenny Nieters, Dr. Nieters. Would you like me to read the question for you?
I'm good.
Okay,
These
so
guys are a hard act to follow here, though.
Well,
I love it, though. I love...
Just FYI, the next question we have, you're going to go first. We'll just reverse the order.
All righty then.
Okay.
So basically, you know, I just, it's hard to say anything new, but I will say that based on my assessment, my patients are either having, you know, pain due to acute recent trauma, or they're having some dysfunctional movement that either comes from their recent acute trauma or their way of repetitively moving, loading their body, how they walk, if they're playing video games in their off time for many hours, you know, just how we do in terms of our repetitive movements and how we load our joints and how that can impact our joints, our fascia, our muscles, and every our spirit as well, you know. So this week I was in Colorado Springs, where my team was trying to train at high altitude so that they could play next Monday in Mexico City. And so I was doing some points to support lung function while I was there, including lung 1 and 2. And my understanding of those points is that they're impacting the nerves that are impacting the pectoral muscles. So whether that opens up the chest so that people can breathe better, or if there's another mechanism to those points, but those were part of my point prescription. But in addition to looking at those systemic points where I'm trying to support the whole body, and maybe yin tong to calm the mind and some such thing there, I'm also looking at what is their, you know, chief complaint. One person came in with, oh, my quad tendon hurts when I squat. So I'm going to go ahead and squat. I want to watch and see what happens. And I could see that his opposite hip was lacking internal rotation. So he was shifting his weight over to the one side and overloading that side. So instead of going to the painful quad tendon, I worked on his internal and external rotation of his opposite hip. And then we found, you know, some trigger points in the fascia. We found some weakness and inhibition of the muscles. So we activated the muscles that were inhibited and not working well. We released the muscles that had trigger points, and we did some neurofunctional points like the obturator nerve trunk at liver 10 to, you know, help that femur rotate. And once we did that, he had no pain in the quad tendon, so on the opposite side. So just looking at how people are loading the joints, and then what is the structure that I'm trying to needle and for what purpose, and then having a way to check myself after to see, okay, did this accomplish what we needed to accomplish? So.
Oh, that's great. Thank you so much, Dr. Nieters. Really, really appreciate that. Well, this was a great start, you guys. Brian, do you want to take it over with the next question?
Yeah, do we have time for a follow-up question on that one? It would have to be a short answer, but I want to come back to the idea of the physiology of the point. So if it's a painful point, are you thinking, and many of you mentioned you're treating multiple different types of point, acupuncture points, trigger points. What's the underlying mechanism that you're trying to change? Are you trying to change the neuromuscular aspect through changing muscle tone with the needle? Or are you trying to change the fascial? Dr. Stecco mentioned a lot about the densification of the fascia. Are you trying to change the fascial aspect? Is there anything specific you're trying to change with the reactive points? And since it's a follow-up question, it'll have to be a very brief answer. Not everyone has to answer, but if anyone wants to jump in on that, I think that'd be great.
Shall I go first?
Yeah.
So, well, we treat what we call densification. What is densification? It's a change of the viscosity of the extracellular matrix, or better, of the loose connective tissue. And by the way, the chief component of the loose connective tissue is the hyaluronan or hyaluronic acid. So we have proved, and a lot of bioengineers have done even before us in vitro, that the lubricant, that our typical hyaluronan, can become more viscous, can aggregate. Okay, so that means that it doesn't bind the water anymore. It becomes like a huge macromolecular crowding that will exponentially increase the viscosity of our natural lubricant. So the lubricant is between fascial layer, between muscle and fascia, within the muscle, in the endomysium, perimysium. So this will generate immediately stiffness, and stiffness is mean poor biomechanics. And poor biomechanics mean like your joint will suffer, your joint will generate, you know, an injury over time. So the purpose of our treatment is to restore the normal viscosity. So a deep friction over our center of coordination that for biomechanical point of view are very important point that has to glide properly. So we apply this friction over there. It will warm up the tissue because the lack of gliding will generate a huge friction over this area. And so we can restore the normal gliding, restore the way the muscle spindle will fire, restore the normal vector that will discharge over the joint.
Do you, I know in a lot of the classes primarily teach kind of a manual manipulation to help rehydrate the tissue, but you work a lot with acupuncturists. How do you incorporate the acupuncture aspect, or is it a combination when you're working with acupuncturists that you are teaching them?
Well, honestly, we teach the way, the guideline to define which point has to be treated in each single patient for each single syndrome. Then we don't care as much if you do manually, with needle, with shockwave, okay, with any other tools. Okay. Because at the end of the day, it's more important that you restore the normal gliding over there. It can be done in many, many different ways. We teach a lot of course in China, and they are really exciting to see a Western way to explain their concept. And they see that there is a different way to restore the normal physiology over the central coordination. So again, it's more important where you apply, sometimes how you apply the treatment. And again, for us, it's important to restore the normal physiology over there.
He pretty much nailed that on the head, talking about where to apply. This is what I think everybody's been talking about, is like finding that source of the problem. Where can you apply the technique and then observe the results? Yeah, this is fantastic. Does anybody else want to comment on what Brian's question was?
Can you repeat the question, Brian, real quick?
Yeah, just a lot of you gave some really great ideas on how you treat, but one of the original question also had to do with your understanding of the physiology of the reactive painful point, ashi points, trigger points, if you're using it, if you're thinking it more from a trigger point standpoint. How does your understanding of that physiology affect how you treat? So what is it you're trying to change? Are you trying to change the fascia? Dr. Stecco is just mentioning that densified fascia and how it can alter the communication that the body's reading, the body's registering, to be able to see how to coordinate these activities between synergists and antagonists. So the underlying mechanism of the fascia is that, are you looking at changing the fascia? Are you looking at changing the muscle in terms of its contractile aspect? What is it? It's a large question, and it could be more than one.
For a muscle that is too soft and too, then I might be trying to activate it so that it has more tone and activation to support the joint. If it is like rock hard and solid, like say someone I had who had just had an Achilles rupture about a year ago, their whole calf was just like a hard rock, and everything felt stuck together and like dried out, like dry tendons, the way they talk about in the books. And we did needle trigger points that we just went after very carefully and individually, and trying to get into the fascial planes. And after about maybe 15 minutes, the whole calf was just like soft and pliable, and you could feel that there was blood flow. I'm imagining that hyaluronic acid was that hyaluron was released, and then you could feel the separation between the tissues. And the person had so much more range of motion in their ankle, and the ability to push off that foot. So it seems like being able to soften what's hard and increase the tone in something that is too soft is it could be either way.
Can I add some?
Sure, absolutely, please.
Research has shown that when you throw electricity through the muscle and the muscle contracts, that electricity is being dispersed through all the cells. So what I like to do is if there are specific points in certain muscles, then I'll hit those motor points. And depending on what the pathology, if I'm trying to reduce inflammation or trying to increase that sliding filament effect to clean out the debris in the muscle cells, I'll pick a specific dosage for that. And I want the muscle to contract a little bit. And that will show that particular electrical dosage and that charge is having that, which I support everything in research, that specific effect on the tissues. That helps. Another way of approaching it with EA.
Yeah, and I know in your system you have a lot of understanding of what frequency to use and how that's going to affect and neuromodulate. So it's very much of a neurological perspective.
Yes, yeah, definitely based a lot of neurophysiology, but the dosages and the electrical currents, everything's all research supported. So what's good about that is when you apply it and you see the effect, when you observe it, that's happening in the tissue with those specific parameters. So that always just gives you confidence, and you can see that as well. So depending on the state of that environment, you could choose different dosages to modulate it.
All right. Matt, do you want to ask the next question?
Yeah, I would jump into number 3 because you guys have done such a great job. You've actually covered 1 and 2. So
yeah.
I think that's number 3. And this is good. Let's just taking a little sidebar here. Thinking about patients, what are your thoughts on myofascial pain syndromes not being primarily a functional or biomechanical source? Now, let's talk about this a little bit more. We may see that there's definitely postural disparities that are going on, and it makes a lot of sense that why this person is having pain, but how much of it sometimes is going to actually be more of an internal component, their psyche, internal aspect. How do you address that? How do you assess it?
Oh yeah.
Michael, why don't you jump on it then?
So absolutely, right? So if there is a psychological component to it, that's what I was mentioning with the scalp system, the auricular system. We could hit dopamine receptors. We could hit regions of the brain to neuromodulate if there's depression with them. If they're having insomnia or they can't sleep properly from the condition, then there's things to rehabilitate in the brainstem. And acupuncture and neuropuncture with the research has those very confident prescriptions that is research support that we're activating those receptors in those regions of the brain to rehabilitate them back into health. And I think those are really nice, confident things you can use in those systems. So I think that is one thing, definitely. You can use those other systems to get the internal thing. There's also points we can use, again, with specific dosages that target the neuroendocrine system for pituitary and hormone regulation with myofascial pain syndromes. And like you're saying, Matt, what's the underlying cause? What if it's immune? Well, we got prescriptions that regulate the immune system. It could be an autoimmune condition. It could be maybe a hormonal issue, or even maybe an infection or some type of, infection that's underlying that's causing, some type of, systemic inflammation with myofascial pain syndrome.
Great. Thank you, Michael. Does anybody else want to add something to that?
I'd like to, if you don't mind.
Sure, come on in.
So, in my assessment of, I'm going to go back to my focus is primarily my practice with athletes. I do, in the beginning, especially the initial assessment of heart rate variability. And it gives me a good quantification of autonomic dysregulation. And like Michael was addressing, with that, I'm able to see in real time if auricular and scalp points can augment that. And using different frequencies with EA, you can really make changes in that. And that's why I try to use a lot of assessments in the sense of looking at using MOXIE for O2 saturation in tissue and musculoskeletal ultrasound to see if there's changes locally, and also with thermography to look at different blood flow and temperature changes, all back correlating again with autonomic dysregulation. And fortunately for me, a lot of the athletes come with blood work and a lot of different nutritional testing to look at deficiencies that may be existing. And so I'm privy to a lot of that, which is very helpful. And I think in the utilization of EA, especially scalp and auricular, I'm able to make significant changes in their heart rate variability to improve their quality of sleep, to improve their emotional state. And so that's one of the ways I approach that component when it's not necessarily a articular or exactly a soft tissue issue.
Excellent. It's nice having a lot of tools in the tool bag for sure. That's good. Thank you very much, Lorenzo. Anybody else have anything to offer about this?
I would just
I can add something. Oh, well, go ahead, Jenny. Go ahead.
I would just say that, when I first started studying orthopedics, and we were sort of parsing it out by body part, and I was getting really, really focused on kind of separating things out to try and figure things out, I asked my teacher, Whit, are we just, kind of throwing out Chinese medicine and all of this kind of rich history and all of, and just kind of treating the supraspinatus, like, and he, or whatever it is. And he said, no, we are never not treating the spirit, because we are all, the spirit and the form and the function are all interwoven and they're connected. You can't treat one and not treat the other. And that kind of helped me have some peace in my heart about, like, oh, am I just throwing out what I found so beautiful about the medicine to start with, by kind of trying to dissect where's this primary stagnation in this anatomical sense of looking at the body. Is it a neurovascular issue? Is it an endocrine issue? Is it, we have these beautiful tools of labs and just, even just listening to someone and hearing where they're at and seeing if they're sleeping and if they're digesting, and, is their back pain really kidney stones related? There's other things that cause pain. But I'm in this athletic population, working with people who are looking for that, high level integration of body, mind, and spirit so that they can just perform at their best. So they want to sleep well, and they're open to me doing points that can support sleep, or looking at their tongue and, feeling their pulse and seeing a change in those things, because they want to, thrive. So.
And of course, there's also the visceral component, as Matt was mentioning too. And I presented recently at the Pacific Symposium, and it was on thoracolumbar junction syndrome, which, has a particular discussion etiology literature-wise, but it really seems to me pretty obvious that it's a good example of a spinal segmental sensitization of that region of the thoracolumbar junction, which also innervates the adrenal glands and the kidneys and the midgut. And oftentimes with those patients, you'll find that they have complaints in irritable bowel syndrome, or, they're exhausted and they overwork, or whatever the case is. So how integrated that communication is between the muscles and the trigger points that can be part of that referral pattern, and the organs and the viscera. And of course, the psyche is going to affect all of that too. So definitely it's important when you're looking at these myofascial pain syndromes to understand that holistic integrative aspect.
Yeah, if we can add something,
sure.
Of course, fascia, we try to, explain worldwide that it's like the organ for proprioception. So it's really well innervated. So more than tendon, more than ligament. And at the same level, the muscle, but with many more free nerve endings. So for sure, we have the capacity to perceive our body. And of course, if the fascism is alterated, you have a disperception of your body. And this can lead to pain, it can lead a lot of disorder. just think about like the gala capitis. The gala capitis cover all our skull. So in the moment the gala capitis becomes stiff, imagine you have like a bag that's pulling down your head. Okay, so you have a complete disperception of your body that can lead not just for headaches, but just like the pressure, like different approach to the environment. And of course, has to be local, because the tension from the lower upper back, it can lead to tension in the gala capitis, and so altered completely your perception, your way of being in contact with the environment. So there is like many way that you can improve. Is, as we always say, you don't have to approach locally to this disorder, because it's always like a global, like the good stuff, the important principle of the fascial system, that you can work even distally to the area of the symptom. You can approach patient in acute situation, work from distally, because you have this capacity. The anatomy of the fascia will allow you to do that.
And just, I'm sorry, just quickly. I think, I know I'm describing a lot of tools that I use to quantify my assessment, but the beauty of what I've learned through my acupuncture training is through palpation, through tongue diagnosis, through pulse diagnosis. I use those other tools to confirm what I'm seeing. And I think I'm not as, I've been longer a physical therapist than I have an acupuncturist. And so part of me feels I need to check myself to make sure what I see is what I see and what I feel is what I feel. And the beauty of all this that we're discussing, and just like Dr. Stecco mentioned, is that you're going to make changes no matter if you work from close to the pain source or away from the pain source, because of the continuity of this entire system. And I think that's what acupuncture has taught me, is that we can make changes, and we can see those changes through the tongue, through the pulse. And I'm very grateful for my training in acupuncture to shed that light on me, and it allows me to even understand further the work of Dr. Stecco and so forth.
Nice. And if I can add just one thing as well, we all do practice acupuncture, and I do neuroscience acupuncture, but I still keep the holistic TCM model. So I'm still applying all that beautiful wholeness and wellness and support, whether it be like digestion, like Jenny was mentioning, or nutraceutical, herbal medicine, tweenah, bone setting, injections, moxibustion, lasers. I like to use a lot of different modalities to just support different areas of the body as well.
Excellent. Thank you so much. I really appreciate that. And this is more about the panelists, but with this discussion, I got to say something. Is that in my 30 years of treating patients and looking at the relevance of kidneys and fear, liver with anger, it's amazing how you see patients coming in with greater trochanteric bursitis or a glute medius strain. You start doing the question, and they really are not liking their partner. They're really feeling trapped about their boss or something of that nature. So you start to see the correlations between liver qi stagnation, the liver channel, its Biao-Li pair, the associated pair of gallbladder, and pain. And if I was just going to go ahead and treat the glute medius strain or greater trochanteric bursitis, yes, the person would be better. But for long-lasting results, is getting into actually what's happening with that liver organ. And simple things. It's just simple. Something that you can be able to mention that's going to be loving for that person. Sometimes I feel like maybe my acupuncture didn't work very well, but that one sentence that I said that was very heartful for that patient and it landed, maybe that's what actually made the pain go away.
Nice.
Well, you guys, thank you very much for all of this. I think we probably have a lot of questions that are going to be coming. Are we going to be moderating this, Brian, or is David stepping in for this one? How are we doing this?
I think we were, and I don't see any questions listed now. So I think now would be a time if you wanted to ask a question, why don't you put it into the question field, and if there are a bunch of questions, then maybe I'll need a little assistance from David to make sure I'm seeing it correctly. But feel free to type in a question, and we will present that to all of the panelists, or if you have a particular person you want to ask, that's fine too. Follow-up question to something they might have said. So now is your chance for that.
Is that for me?
And I'm seeing not anything answered on the poll either. So I'm thinking that something's awry on my end of it. There's a question that came in.
Okay.
I can read this if you like.
Go ahead.
So Max, welcome. It's good to see your name. How much do you use the stretch response to create change, glide, and fascia in your respective practices? I'm anticipating that's proprioceptive neuromuscular facilitated stretching, I'm guessing. How much do you use the stretch response to create change, glide, and fascia? Does anybody want to jump on that?
I use PNF.
Oh,
Yeah.
I mean, if it's about fascia, maybe I can say something about that. So, of course, I mean, stretch, it can be like a mechanical stretch that you perform, or we can talk about stretching the area. If you mechanically stress or stretch the fascia, okay, that can lead to restore the gliding in a short amount of time. Everything is related to chronicity. How long the patient had like such a lack of gliding in the fascia, how long it will take the restoration of the gliding. But we talk about like minutes. It can be like in a very like short-term symptom, like a few months. It can be less than 1 minute. I mean, if it's 20 year, 30 year, there's a lack of gliding, can be like a 3, 4, 5 minutes. Okay, so that is only related to chronicity and not even to the severity of the symptom, because the patient can be really, in excruciating pain, and maybe it take like just 20 seconds to release the alteration. At the opposite, the patient can come in, walk in the office and say, look, today I'm pretty good, but I'm suffer from a lot of pain since 30 years, and then you find out that you will spend a little bit of time to restore the gliding mechanically. If you just prescribe stretching, that it will help to maintain the result, but it will not resolve, unfortunately. So that can be like a good advice to the patient. So look, we have restored the biomechanics, you're good to go. I mean, go ahead with your sport, go ahead with your work, but add some stretching at the end of the work of the sport to try to maintain the adaptability of the fascial system, to try to maintain the result and do not have a recurrency of the symptom.
Mm-hmm. Okay. Thank you very much, Dr. Stecco. Anybody else, or should we jump into the next question? Okay. What is your approach for structural problems like scoliosis in a young child?
Nice.
Is it functional scoliosis or is it structural scoliosis? Probably structural, I'm guessing. I've got some answers with this one, but I'm sure you guys do as well. So once somebody take that away.
Define child. What age? So if they're like in their early teens or even younger,
I'm guessing that.
See, under 10, that would be, I do extra EA on every patient. And
the question is from Gail Nolan. It is structural scoliosis and is from ages 10 to 11.
10 to 11. Okay. Well, I do like to do needling with E-stem. I have different dosages that we use on the curve, micro and milli, depending on the way the spine is curved. I don't know if I've ever worked on anyone that young, but I also do a lot of gua sha and tuina on that. And I was trained in traditional tuina, so traditional Chinese bone setting. It's not high velocity. It's very slow, but it definitely puts the bones back in place. Not that I'm going to, that I'm aiming to do that, but 10 and 11-year-old, I think I might still use ear needles and just do the Huatou Jiajis and just tap them through, and you can run micro and milli on different sides. I might even try to do that and then just do some nice gua sha along those, the dorsal processes. That would be I think that would be my approach.
Great. I have an approach I can mention since I am not a panelist, but it'll be brief. And that is structure is very important to look at But to me, it's a window into function. So, you know, if somebody's ilium's elevated and you can ascertain from that that maybe certain structures are in a shortened position and aggravating that. But to me, it's always a not a precise window into function, but a glimpse into function. So when you're working with something like scoliosis, that's a structural scoliosis, you're not going to get everything back in the line, so to speak. But you can still work with function and improve function and getting things gliding properly and moving properly. And you just have to let go of the idea of having a perfect oriented spine, because there's really no such thing as that with anybody, and especially somebody with scoliosis. So function is sort of the number one thing with that. The other thing is, if I have scoliosis, then gravity is going to start acting on that and pulling it down more. So I can return some of that length back to the body without me trying to get my ego involved and saying there needs to be more. I need to push more and get it straighter, but I can return some of that effect that gravity and that compensation that's added to that over time has started to make it worse. So that's my general kind of simple approach for scoliosis that's structural based.
Anybody else want to comment?
You know what? I think you're muted.
You're muted.
Sorry about that.
Yeah, no worries.
From my PT background, we will definitely, I definitely attack it with exercise as well.
Yeah.
And I incorporate both soft tissue and exercise. I do use some taping to give the child some awareness of position that I gradually work towards removing and not having it be sort of a crutch. Sometimes bracing is necessary as well early on to support repositioning of that patient, but then gradually transitioning to where there's a lot of self-care through exercise and activity and understanding, and also this making aware, where should your body try to go towards and how do you get there, what's keeping you. And it's just a lot of education early on with a lot of exercise, but I do incorporate some soft tissue, some gentle needling into areas that I feel are epicenters of restriction that the body has tried to compensate their movement. And that's how I sort of work from that position and get them as functional as possible.
Yeah, there's those crux spinal bends. And what I could add to that too, I think, is the importance of looking at the diaphragm and the abdominals with that. Yep. So there's, I mean, we could take this topic and go all night with this discussion.
Sure.
Let me jump into another question. Is that all right? Okay. How do you fashion treatments for pre-adolescent athletes, especially those with flat feet, pes planus, and tight hamstrings? Contract, relax, so a PNF type of stretch. Do you incorporate other modalities of moxa, tuina, etc.? Anybody want to jump on that?
I can continue just from based off the last question with the scoliosis. I don't necessarily feel flat feet's an issue if it's functional. Tight hamstrings is usually not tight hamstrings. I would look at pelvis positioning. If they have an anterior pelvic tilt, most likely pre-adolescent children, athletes are going to be very quad dominant with an inability to activate glute or posterior chain. And so I would look at restoring activity to the counter muscles to offset the load on the hamstrings or the tensile force on the hamstrings. And then just gradually work on, again, strengthening that child without predisposing undue stress to growth plates and things of that nature.
Yeah, excellent.
Michael,
what about orthotics, Lorenzo? Is that something you would recommend for your patients if they were that young and they had flat feet? 4 inches?
I hate to say it depends, but it depends. But
right.
I'm not against it. What I will instruct them is that it's something that we may do at the beginning phase. If I feel that the flat foot is compromising the integrity of the entire body, then we do that support, but then we focus on strengthening the feet and working up and then gradually removing the insert amount to the point where we can actually remove the insert.
Yeah, kind of as a last resort, trying to get rid of them. Yeah, I agree. Excellent. Thanks, you guys. Really appreciate that. Here's an interesting question. I think it needs a little bit more clarification, though, at least for me. What role does manual motor testing play in your assessment? Is this manual muscle testing? Is this functional assessment? I'm not exactly sure what direction we're going with manual motor testing. So, Adrian, if you can be able to bounce back with us and let us know so we can be more refined with that, that would be great. While we're waiting on Adrian, we have something from Scott. How would you use electroacupuncture with spinal fusions to mediate post-surgical muscle pain and tension? Example, C4, C5 fusion due to trauma.
So, want me to jump on that one?
Yeah.
Okay. So, if it's a fusion, you have to ask first, always, where's the hardware, right? Is it anterior? Is it posterior? And what you really need to be careful of is make sure the needles are not touching the metal. That's what I've always been very, very, very cautious of and always been very careful of. And research usually supports that. Doesn't mean you can be reckless and throw a bunch of Huatos and throw needles and knee stem through that. But I do knee stem through that. I would definitely do that. I would definitely do some Huatos, deep Huatos, tap that process if you can. I think that's really important, just to loosen up those tissues that are going to be tight from that fusion. And most likely it's probably an anterior fusion, so that the hardware will be on the front. And I think that's fine, throwing some current through there, especially if you use microcurrent in the beginning, just to reduce inflammation and start to repair any soft tissue damage.
Okay, excellent. Thank you so much. Adrian, to get back to us about what role does manual motor testing play in your assessment? Yes, it's manual muscle testing. For me, I use manual muscle testing on almost every patient just because it gives me a lot of information. It helps me quite a bit. Anybody else want to be able to comment on that?
It's a regular part of my assessment.
Mm-hmm. Yeah, good.
I think, Dr. Stecco, are you talking? I thought you were muted, if so.
Well, no. Well, I can say that even my approach, manual testing, muscle testing, is important. I mean, it's not just to check the strength, but I will check what we call densification. So how much rigidity we will feel over that area. And by the way, I mean, literature doesn't support as much that the typical orthopedic test is going to really lead to the clear diagnosis of what has to be done. A lot of orthopedic tests are sensitive but not specific. So at the end of the day, I will trust more my palpation. So the skill to understand where there's a good gliding, so good physiology, when there's a lack of gliding, so what we call densification. That is really the key for us to understand the biomechanical problem that is in the not just fascial system, but in the entire musculoskeletal system. And then from there, we will make like our protocol for the day. Then you can use a lot of orthopedic tests, but just to retest if you have done your job. But again, start for the regular orthopedic test. In my opinion, you miss a lot of the picture of the typical case that you have in front of you.
Right, I agree with that, and I think manual muscle testing is going to be very important to be able to have, but also you combine that with other things. I totally agree with you, Dr. Stecco. We've got another question that just came rolling in. Question regarding treatments for athletes. What are your must-use acupuncture points, not including motor points, from a physical and or mental recovery standpoint? Oh my gosh, there's a lot that could be talked about.
Yeah.
So what are your must-use acupuncture points, not including motor points? Mini
I got one.
Points.
I got something easy. Something super easy, right? Something super easy. I call anterotibialis neuropuncture point, stomach 36 bilateral, 2 hertz millicurrent, 30 minutes. Nitric oxide release, pancreatic, hepatic enzyme release for digestion, intestinal motility, keeps your immune system strong, has neuroprotective effects on the brain. Simple and easy. You could even pair with spleen 6, which call the tibial neuropuncture point, and get even a bigger impact with some neuroendocrine support. So those are big points in TCM. They do have big impacts on the body. And 2 hertz milli, just for the audience, what does everyone think that might be? It's so simple, right? 2 hertz millicurrent on every machine you have it. And what that replicates is lifting and thrusting. So every time they were doing lifting and thrusting for thousands of years, that's mimicked now with 2 Hertz milli. And 2 Hertz milli current in research has a profound effect on so many structures and receptors that's targeted. So it's really nice, simple. On stomach 36, that's a really nice point, nice, simple prescription. You can do other things on the scalp for dopamine and serotonin and GABA, but for keeping it simple, can't go wrong with that.
So the question is regarding treatments for the use of athletes. So for this is something that I wrote in my book talking about, is it more of an upper extremity type of sport? Is it more of a lower extremity type of sport? Is it a combinational sport? And that's going to predicate what different points that you could be able to use.
I know Shin, he's talking baseball probably. I know,
oh, you know this?
Yeah. So.
Okay. So it looks like we have a question for you, Mr. Dr. Corradino. Would you mind elaborating on your frequencies, parameters for acute versus chronic pain? Are you able to do that in just a couple minutes, Michael?
Not really. I don't want to. I think that's really best for the conference, because it's really specific with voltages and specific numbers, and there's a progression that we use, and each frequency I use specifics, target specific tissues from muscle, nerve, to tendon and bone. And then on the acute versus chronic, it depends as well. So wouldn't want to just throw something out there lazily and give someone the wrong direction. I have plenty of content online, and the conference will be going over all that. Trust me.
I agree. All right, we've got time for just about 2 more questions, and I actually would like to be able to direct this to Dr. Stecco. This question from Gerald: how do you deal with tendinopathies such as de Quervain's?
All right, excellent question. Are we really think that that is the target of the de Quervain come up overnight without reason? I mean, our idea is that nothing happened, by chance. I mean, there's always a reason why something happened. Okay, of course, de Quervain would be mostly due to overuse if we run out any specific trauma. So when you run out trauma, just think about that. It's something happened there, de Quervain assists, pain in that area, because there is a poor biomechanics. I mean, body is able to self-healing, okay? So in the question that we normally, the concept that we normally explain that, look, we are built up to live until 40. Now we live until 80, okay? So our body had to try to adapt to this long, life. But we have to keep our biomechanics at the best for such a long time. So we saw that the densification, this rigidity of the fascial system occur because they adapt to our necessities. So overuse will increase the stiffness, but it's a strategy to try to facilitate that movement in the short term, but it doesn't work for long term. So if you are doing like a coffee machine, if you do like 100 coffee every day, in front of a Starbucks bar, of course you will have an overuse. So in the short term, it can help you because you strengthen it, you create a reinforcement. In the middle term, you create a fascial reinforcement. You really see an increase in number of collagen fiber that will help you in the short term, but not in long term. So this at the end will generate like an increase of the stiffness that will affect the distal joint or the proximal joint. So at the end of the day, you don't have to be aggressive over the area of the symptom, because that is just where the incorrect vector will discharge, like too much tension in that tendon will occur. The pulley will become more rigid because there's more tension in the underlying tendon. So try to go at the beginning of the problem. Try to restore the normal gliding, the normal physiology at the beginning where the vector is generated. And then you will see that the body will heal by itself in the area of the symptom. The cyst will decrease, the inflammation of the paratendon will decrease. And remember, the most innervated symptom tissue is not the tendon at all, it's the paratendon, the tendon sheath that is way more innervated. So first of all, think about what is innervated, what tissue can generate the pain. And second, think about what is the first moment, what is the first element that generates the problem, and work there. Don't be aggressive over there of the symptom. That a lot of time is just the manifestation of the problem, not the origin of the problem. Body is able to heal if you restore the normal environment. You just have to figure it out where is the problem.
That's the key point right there. You got to figure out where the problem is. And I think all of us can agree when a patient's coming in with certain pain, it's not really there. That's just the innocent bystander. We have to look at someplace else. Yeah, excellent. You guys have time for one more?
Sure.
Okay.
Yeah.
Any success with needling spondylolisthesis that's showing signs of cord compression? I've got
so needling that, is, I personally think it takes more than needling an EA. Definitely a lot of manual work and ways you have to try to work to manually help pull that bone back up. There are, you could use burst frequencies of millicurrent, sure, to help exercise those tissues and to strengthen them if that's what's causing that slippage. But also there's techniques in between that you need to use that I was taught to pull the bone back up. I'm sure there's some physical medicine as well.
Lots to talk about on that one. I think, Lorenzo, you're probably chomping at the bit on this one, I think, right? You gonna say something?
Well, I think, there's stages of spondylolisthesis, right? There's different grades of it and the severity of it. And if someone's showing signs of cord compression, you want to make sure they're not having bowel or bladder issues, right? Saddle paresthesia, any other neurological symptoms that would be indicative of, an emergency where they should probably go to an ER. But barring that, I would probably work again. The way I look at it is, okay, we have an issue there's a segment or anatomy that's compromised, so let's support it. So I would use some sort of bracing post-treatment so that the person can be stabilized until they can stabilize themselves. So a lot of the, eventual progress with EA can be to activate TA, right? Transverse abdominis, to try to activate external obliques, internal obliques, to create our natural girdle, help facilitate movement of that spinal segment and minimize the compression or further progression of the cord.
Yeah, excellent. And Jenny, this is actually something you're going to be talking about, is core stability at the SOAS event coming up in March. Is there anything you want to offer to that?
Well, I was just thinking about what Antonio had said about how the body does want to heal itself. And I always, when I have a patient like that, if there's a nerve compression and there's, motor deficit, then I definitely want to know, I want to refer them out for imaging first and foremost, because I want to know how severe that compression is and if it's a surgical case or if it's something we can work at with my acupuncture, working on the larger stabilizing muscles, those kind of wraparound muscles that are attaching to the spine, stabilizing it. And then I really want them also working with a PT to develop the strength to support their body so that it can come more into alignment. And then in the meantime, as they're working that, I'm going to help them with acupuncture. And I have worked with several people who, were trying to avoid surgery and were successful in doing that. But I never want to, be alone in that process. I want to have a team. I want to know that they have an orthopedist that's on board, because I don't want someone to have, any permanent damage, even though we're seeing progress and, it's okay. And I want them to have a PT.
Yeah. Can I add something about that? Just a quick little story, anecdotal story. I had a patient that was a former pro golfer, and he was working on the gym, was holding kettlebell, moved quick, felt pain in his back, so had sharp pain and drop foot. So he comes to see me because I knew him, and within literally less than probably about 10 days, pain was down to a 0. It was at like a 12 out of a 10 when he first came in, but drop foot was not getting corrected. I immediately sent him to one of my spine surgeons that I was teamed up with. He immediately got an image, emergency discectomy, and he's like, I went to the surgeon. He's like, yo, Mike, good catch with that. He's like, because that was debris that shot from his disc onto his cord, and if we didn't take care of that in time, we would have permanent nerve damage and drop foot. And because I know, neurophysiology, we look at that. What's benefit? Yes, the pain's going down. We could target receptors. We could definitely modulate the sensory system, but the motor system was not working. There was something that still needed attention. And I referred him immediately out. So yeah, absolutely. I missed that. Thanks, Lorenzo and Jen, for picking up in the beginning. First and foremost, yeah, is there any neurological deficits? Because if that cord's getting compressed, no excuses. Get him out immediately for surgery or at least ER.
I'm not sure if you guys are all seeing this like I am, but I'm seeing a lot of like emojis on my.
Yeah, it's
What's going on? I'm not getting any of those.
No, it's
Ryan, you get those?
I'm not sure if they're just coming.
that personally.
Not to take it away from
Oh, they're for
not to take
everyone.
away from Michael, but I think they're just coming up from that corner.
Oh yeah, that's for everyone. Oh no, yeah, that's not just for me, Matt. No, that's for everyone. Yeah.
But I'm sure some of them are for you. I don't want to take it away.
No.
Oh, that's hilarious. You guys, we have had a great time. This has been really, really great. We're going to have to wrap this up. I want to thank L.A.C. OMS for putting this all together. We've been planning this for quite a few months. And David and Stephen and Todd, thank you so much for all of your work with this. And it's been fantastic to see. Did we just lose Antonio? Dr. Stecco, if you're still there, thank you so much for coming. And oh my goodness, if you are this exciting at 3 o'clock in the morning in Italy, I can't wait to see you. Actually, yeah. So Dr. Nieters, Jenny, thank you so much for coming. Michael, Dr. Corradino, it's been a real big pleasure. And Lorenzo, thank you so much. Really appreciate it. Brian, it's always nice hanging out with you. And I'm glad that we actually be able to pull this off. And thank you again, L.A.C. OMS. For all you guys that have been hanging out and listening to us, I hope this has been really useful for you. And hopefully we can be able to see you at the SOAS event in San Diego, March 30th through April 3rd. Any questions whatsoever, you can reach out to us at soaseducation.com.
And don't forget to answer the polls.
Oh, good one. Yeah, thank you.
Answer the polls. You'll notice out in the chat, everyone visit losoms.com and use MCWeb15 for 15% off your next order. That code expires on 12/16. Thank you, Matt. Thank you, Brian. Thank you, all the panelists. Amazing night. And we'll look forward to seeing you guys at SOAS.
Awesome.
Thank you, guys.
Thanks,
Thank
everybody.
you. Thank you, ciao, guys.
Right. Okay, bye-bye.
Bye-bye.
Bye now.